Great. I'm so excited for our next speaker. We're so lucky to have her, Dr. Priscilla Brastianos from Mass General. Her title is Research in CNS Metastases. The Care Starts in Your Lab. And she is the director of the Central Nervous System Metastases Center at Mass General Hospital and leads a multi-R01 funded laboratory. Dr. Brastianos' research focuses on understanding the genomic mechanisms that drive primary and metastatic brain tumors. She leads so many studies, and she has led studies that have then identified novel therapeutic targets in brain tumors and brain metastases. And she has translated her scientific findings to national multi-center trials. She also leads a multidisciplinary CNS Metastases clinic at Mass General and at Harvard. And she's received so many different awards for her work, both as a lab researcher, a true translational researcher, and with her clinical trials. And she's also mom to very cute, almost, I think, maybe 1-year-old Leo at this point, which also I think is a testament to her as a great researcher and physician, and has many loved patients around the country. So I'll turn it over to Priscilla, Dr. Brastianos, for her great talk.
Thank you. Thanks so much for the very kind introduction, Priya, and thank you to you and to ABTA for organizing such a wonderful day. It's fantastic to be here to talk to you all today. And Priya and I have worked together for many, many years, and it's been wonderful working with you. Obviously, Priya, you've done fantastic work for patients. So today I'm going to focus on some of the research that we're doing, but some of the research that has led to clinical trials. I do apologize in advance if I have a screaming 1-year-old in the background. He is running around and playing right now. So apologize for that. So I was going to talk about precision medicine, specifically in brain metastases, and how that may change how we manage patients in the future. These are my disclosures. So here are the 3 objectives of my talk today. One is to explain the challenges in the treatment for patients with brain metastases. So what are the challenges that we do encounter? Demonstrate the impact that precision medicine approaches are having on the management of patients with brain metastases. And finally, demonstrate how bench to bedside approaches can help us identify potential new therapies for patients. And I'll talk a little bit about the research that we're doing for that 3rd point. So you heard this from Dr. Kamthekar. So brain metastases, unfortunately, there's still an unmet clinical need. We need to do more for patients with brain metastases. They're in fact the most common cancer of the brain. Most patients with brain metastases have cancer from lung, breast, and melanoma. And unfortunately, historically, clinical trials have commonly excluded patients with brain metastases. And we're hoping now this is shifting as more treatments are emerging for patients. And also, this is an important point, is that patients can develop brain metastases even if their cancer outside of the brain is responding to therapy. So as a patient, if you do develop any new neurologic symptoms, even if your cancer outside of your brain is responding, do let your physician know, and additional testing might be necessary. So what are some of the challenges of clinical trials for patients with brain metastases? So in the past, unfortunately, there were a limited number of trials for patients. And as I mentioned, many of the trials did exclude patients with brain metastases. And we are really hoping that the field is changing now. Many were smaller studies and not the larger studies that one sees in breast cancer or lung cancer. So they were smaller studies for patients with brain metastases. And most patients with brain metastases have progressed, unfortunately, on many other therapies by the time they develop brain metastases. So that might make the disease a little bit more challenging to manage. And finally, and this will pertain, this last point will pertain for some of the research I'll show you towards the end of my talk, is in the past, the extent to which brain metastases share therapeutic targets or genetic profile of the primary tumor was unknown. And I'll talk more about why that's relevant later in my talk. So let's briefly talk about, and you heard about this from Dr. Kanthakar, how are patients with brain metastases managed? Well, treatment is typically multidisciplinary. And you saw the care team in Dr. Kanthakar's team and Dr. Kanthakar's talk. Surgery and radiation are often used for local treatment of brain metastases. By local meaning targeting specific brain metastases and targeting the brain itself. Many chemotherapies historically have not crossed the blood-brain barrier, meaning they don't get into the brain as well as they get into other parts of the body, though there are some chemotherapies that do get into the brain better than others. And immunotherapies, which I'll talk about in a few slides, are truly revolutionizing the treatment of many cancers, including in brain metastases from melanoma and from lung cancer. And I'll talk more about what that means in a couple slides. And then targeted therapies, so therapies specifically going after specific molecular alterations in your tumor, are showing a lot of promise in patients with brain metastases. And I hope to convey that to you in the next few slides. So briefly on that point, precision medicine, it's truly revolutionized oncologic care. So what is precision medicine? So you've all heard of this. Precision medicine is when we can target the tumor based on the specific molecular profile of the patient's tumor. And that's really changed the landscape of the treatment of many types of cancers, including melanoma, breast cancer, lung cancer. And we are seeing precision medicine dramatically alter how we manage patients with brain metastases as well. So let me go through some of that now. So here are some examples of trials for patients with melanoma brain metastases. And I'm not going to go through this in too much detail, but I do want to convey to you how much of an impact these newer therapies are making for patients with brain metastases. So this is specifically some of the trials published, and this is by no means a comprehensive list. This is just give some key examples. So the first two trials here that I'm showing you about are looking at chemotherapy. So temozolomide is a common chemotherapy used for brain tumors, and these are two trials that look at it for patients with melanoma brain metastases. And you can see here response rates, which meaning the percent of patients that have responses in the brain, were 7 to 10%. So obviously the goal is to do better than this. And more recently, immunotherapy has really made an impact on how we manage patients with brain metastases. So what is immunotherapy? So my next slide will highlight that. So what do these newer immunotherapies do? So tumors, unfortunately cancers, can put a block on your immune system such that your immune system does not recognize the cancer. What these newer immunotherapies are doing is they block that block so that your T cells or your immune cells can now recognize and fight the cancer. And these immunotherapies, many immunotherapies are now FDA approved for cancer, and many of these immunotherapies now are being looked at in brain metastases and are really showing an impact in brain metastases. So here I show you these two trials here where the response rates you can see are much higher than what the chemotherapy response rate were. And that's for immunotherapy. So now let's briefly look at what the data looks like for targeted treatment. So targeted treatment, BRAF inhibitors and BRAF/MEK inhibitors. You can see here response rates are much higher, again, when you compare to the chemotherapy. So we're doing a lot better. We obviously still need to do a lot more, and that's where the importance of research comes in. But patients are doing better now with the newer therapies. So let's briefly talk about some of the target therapies being looked at for patients with breast cancer brain metastases. So I show you here some of the older trials, again, response rates in looking at this older target therapy was unfortunately only 6%, but when we combine it with chemotherapy, response rates are higher. And there's newer agents such as this newer HER2 agent, tucatinib, where the response rates are much higher in the brain. So targeted therapies are also making an impact for patients with brain metastases. And again, this is not a comprehensive list, just shows you an example of what some of the data looks like for some of the newer targeted therapies for patients with breast cancer brain metastases. Oops. Oh, my slides are going in overdrive. One second, let me go back to that old my other slide. Okay. And what about lung cancer? So here are just some examples of trials looking at EGFR treatment. So EGFR is a target in lung cancer. About 5 to 15% of cancer of patients with lung cancer have have EGFR mutations, and brain metastases are quite common in patients with EGFR mutant lung cancer. And you can see here the response rates in the brain of these different EGFR inhibitors. And some of the newer EGFR inhibitors, such as osimertinib, have much better penetration into the brain. So at the beginning of my talk, I talked about how some of the agents don't necessarily get into the brain as well as they get into other parts of the body. Osimertinib is a newer agent that does get into the brain much better than some of the older EGFR inhibitors. And here are just some examples of another target, so ALK inhibitors for patients with lung cancer brain metastases. So again, here are some of the lists of trials that have looked at these agents, these ALK inhibitors, and the response rates in the brain. Again, you can see just the range of response rates. So what I hope with these last few slides I've conveyed to you is that targeted treatments in some of these newer trials are showing an impact and showing higher response rates for patients with brain metastases. So the management for patients with brain metastases is now shifting. And let me walk you through generally how we think about the management of patients with brain metastases. And again, this might not necessarily pertain to your individual case or individual care, but this gives you a broad overview of what we think about when we are treating patients with brain metastases. So if a patient has newly diagnosed brain metastases, then one of the first questions we ask is, does the patient have symptoms from their brain metastasis? And if they do have symptoms, then we consider local therapy with surgery or radiation. And the decision for surgery or radiation really depends on many different factors, which includes how big your tumor is. Is it causing a lot of mass effect? Meaning, is it causing a lot of pressure in the brain too? How many spots do you have in the brain? And what is your extracranial disease doing? And these are all some of the considerations that come into when we make these multidisciplinary decisions for patients with brain metastases. And if a patient does not have symptoms, then in some cases, we do consider giving systemic treatment if there is a known active drug with CNS or central nervous system activity, such as the drugs I told you about earlier, osimertinib, for example, for patients that have EGFR mutant lung cancer. And if the patient does progress, then here's some of the things we think about. So if the patient progresses, then again, we think, is the patient symptomatic? And if yes, then we consider local therapy again with surgery or radiation. If the patient is not symptomatic from their tumors, from their brain metastases, then we might think about switching systemic therapies if there is a good drug option that gets into the brain. And then at every point of progression, we do consider clinical trials. Because as mentioned, it's really important that we try to find better therapies for patients with brain metastases and try to find newer therapies for patients. So we do consider clinical trial options. And if there is brain metastasis tissue available from a prior surgery that you've had, then it's important to consider doing additional molecular testing or profiling of the tumor to see what the potential drug options are. But let me now, for the last half of my talk or so, go into research and how that hopefully will help us identify more treatments for patients with brain metastases. And some of the treatments I told you about earlier really did, all those treatments did come from work that was done first in the lab and then was taken to clinical trial and then to the clinic. So this was actually a cross-sectional survey that was funded by the American Brain Tumor Association. And it was across physicians, patients, and caregivers. And in this survey, we showed that physicians, patients, and caregivers all indicated the need for increased treatment and research funding for patients with brain metastases and more clinical trial availability. And many of us now are really trying to try to expand the clinical trial options for patients. So let's talk about some of the research we do in the lab, and that'll give you a good sense of, again, how research can potentially translate into clinical trials. So here are some of the unanswered research questions, or questions that we are trying to answer in the lab. So I told you about precision medicine or targetable mutations. So the question is, what are the targetable mutations in brain metastases? And as I had mentioned at the beginning of my talk, patients often progress only in the brain. And can this be due to genetic changes that are different in the brain metastases compared to the original primary tumor, such as the breast cancer or the lung cancer? And finally, can we rely on a primary tumor biopsy when we're making decisions for target therapies for patients with brain metastases? And these are all questions that we're actively trying to answer in the lab. So just to give you a better sense of some of these questions we're trying to answer, let me go through some of the biology of brain metastases. So let's take this back to the science. So what are the different steps that need to happen for a brain metastasis to then travel to the brain? So first, the primary tumor, such as a lung cancer or a breast cancer, need to grow. They need to invade so that they get into the bloodstream, these cancer cells, and they need to spread then to the brain. And then once they survive in the bloodstream and then stop in the brain, then they need to grow in the brain and then develop new blood vessels in order to grow in the brain, to grow in the brain. And different steps, different molecular changes are needed in order for these different steps to occur for metastasis. And as a field, the research is still lacking in understanding exactly what are the drivers that lead to each of these different steps in metastasis. And what our lab and others are trying to do is try to understand how the cancers do spread to the brain and what are the molecular changes that happen in order for the original tumor to then spread to the brain. And in order to do these research efforts, we now have a translational brain metastasis center that we have at MGH, where we have a multidisciplinary brain metastasis clinic, and patients graciously consent to have their tumor samples used for molecular studies, with the goal to take these studies to rational therapeutic targets, to rational therapeutic trials, and to try to bring these back to the clinic. So let me talk briefly about one of our ABTA funded research projects that we started several years ago that is still ongoing, where we try to genomically characterize brain metastases, meaning we're trying to understand what are the genetic targets in the brain compared to the original primary breast cancer, or the original primary melanoma, or original primary lung cancer. So to do this, we've now created a large tumor bank of brain metastases. And these are actually tissue samples that were graciously sent to us from different institutions. And we're so grateful that patients consent to have their tumor tissue samples sent for research. And we have many brain metastases now that we're in the process of genetically characterizing to try to understand what are the targets for patients with brain metastases and how can we take that to clinical trial. And the Brain Tumor Association helped us conduct this large genetic study of tumor samples from patients with brain metastases. So the goal was to genetically characterize, so meaning we're trying to understand the genetic changes in brain metastases compared to the matched original primary breast cancer or primary lung cancer. So the goal of the research is to understand the genetic evolution leading to brain metastases, and then to identify the drug targets for patients with brain metastases. And so this is the ongoing research. So let me take you back even deeper to the science. So for each matched brain metastasis and primary tumor, we map out the genetic relationship, meaning we try to understand where different genetic or molecular alterations occur. Are they in the brain metastasis, as depicted by the red? Are they in the primary tumor, as depicted by the blue? Or are they shared by the brain metastasis in the original primary tumor, depicted by the gray? And what we showed was that the brain metastasis and primary tumor, they did share alterations. They did share many alterations, but then the brain metastasis and the primary tumor had more alterations and they genetically diverged, or they evolutionarily genetically diverged. And we call this branch evolution. So why is this important? Well, we need to know if therapeutic targets are different in the brain compared to the primary tumor, and that's ongoing research. So I like to use this analogy. So Charles Darwin in 1837 mapped out this evolution, or branched evolution. And this is the pattern we're seeing in brain metastases. So the brain metastases do have many of the same alterations as their original primary tumor, but then they're developing more genetic alterations. So then let's take this back to clinic. So do brain metastases harbor targetable mutations that are not in their original primary tumors? And so here's one example, and again, I'll walk you through this. So this is an example of a patient that had a brain metastasis, and the disease outside of her brain was well controlled and was not progressing. And as I had mentioned earlier, this is not an uncommon scenario that we will see, unfortunately, patients that have progressive brain metastases while their disease outside of the brain is stable. And what we showed in this research was that the primary tumor and the brain metastasis shared some alterations. So the gray line here, shared alterations, shared genetic changes, but the brain metastasis had this targetable mutation that was not present in the primary tumor, this EGFR mutation that was not present in the primary tumor. And when we looked across the entire cohort, we actually found that more than half the cases had these clinically actionable alterations in the brain metastasis that were not in the original primary tumor. So we're finding that targetable mutations are common in the brain metastases and might not necessarily have been present in the primary tumor. We obviously now need to do more research to try to understand if we target those alterations, will patients do better by targeting the alterations that are in the brain metastasis? So are there opportunities to target patients with that have brain metastases? So did we find commonalities in the cohort of patients? And indeed, we found some commonalities. So we found that more than half the cases had alterations in CDK inhibitor, alterations in the CDK pathway, and 43% of cases had alterations in the pathway called PI3 kinase pathway. So these are common pathways across brain metastases for which there are inhibitors that target these pathways. And so we were able then to take this to a clinical trial. So this was an example of a bench to bedside approach where we did a biomarker driven trial for patients with brain metastases, meaning we try to target the brain metastasis based on the specific genetic alterations. And we tried to use brain metastasis tissue when it was available for testing. And so this is just one example where we looked at a CDK inhibitor for patients with brain metastases. And here's just some of the early data. So we found that 8 out of the 15 evaluable patients had clinical benefit intracranial, meaning they benefited in the brain, and 7 out of the 15 evaluable patients had benefit outside of the brain. So this was the interim analysis of this phase 2 trial. And based on this, we've now started a national biomarker-driven trial for patients with brain metastases. And this is work that we're doing in collaboration with many institutions throughout the US. So this is now open at more than 400 hospitals throughout the US. And actually, Dr. Kamthekar is also very involved in this study as well. And so specifically, this is a clinical trial now we're running based on the data that we generated in the lab. And it's a biomarker-driven trial for patients with brain metastases. So that's just one example of a trial. If you are interested specifically in looking for trial options in general, here is how to find clinical trials. So the clinicaltrials.gov website will help you access looking for different trials across the country. And it also has lists of institutions that have that trial open. So if you're interested in trials, do look at this, this website here. And if you're interested to find out more about our research, here's our lab website here. So in conclusion, what some of the research is showing is that mapping the genetic profiles of tumors from patients with brain metastases is helping us uncover potential therapeutic targets. And we're looking at those targets now in clinical trials. But what I also hope I conveyed to you is that from some of the earlier slides I showed you, that precision medicine is truly changing the landscape of treatment for patients with metastatic brain tumors. And so we are seeing patients do better, much better than they did 10 or 15 years ago because of these new treatments. So there is lots of hope for patients with brain metastases. And I am looking forward to questions. Thank you again for the opportunity to present today.
Thank you so much for your presentation. As a reminder, if you have questions that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we will answer questions as time allows. All right, so one of the first questions we have here actually goes back to the study that you just shared, the National Biomarker Trial. Where can patients find more information on whether or not their institution participates in this and how they can possibly participate?
Yeah, that's a great question. If you go to the clinicaltrials.gov website, you can find out more information about the trial itself. So if you go to the clinicaltrials.gov website, you can even put in my last name under, and then it'll help you identify, you can actually find that trial there. But for that trial or for any other trials, do look on the clinicaltrials.gov website, and it actually has information for the different sites and also the phone numbers for the different institutions that you can actually use to call to see if you are eligible for that trial.
Thank you so much for sharing that insight. We actually have a question here about the clinicaltrials.gov website. Sometimes it can be a little difficult to navigate. Do you have any advice on navigating through that portal, or any way to find more lay-friendly, easy to understand information on trials that may be appropriate for patients?
Yeah, wonderful question. I completely agree with you. That clinicaltrials.gov website is not an easy website to navigate, and it is very clunky. I completely agree with you. I think one thing you could do is actually sit down with your neuro-oncologist or medical oncologist and look at it with them too. So often what I'll do is sit down with patients and look with patients to see, what are the trial options. So I do think it's worth communicating with your oncologist about helping you navigate that website. And then there are different advocacy organizations also that do have lists of trials as well. But I do think that navigating with your oncologist is going to be really key to trying to help you navigate that website. But I completely agree with you. It's not an easy website to navigate at all.
Great, thank you so much. Another question we have here is just the role of a patient in research and advancing research. You talked about how patients can share their tissue for research. Can you provide more information on how a patient can play a stronger role in advancing research?
Yeah, that's a wonderful and very generous question. So the reason why we have all these treatment options now for patients is because patients have contributed to research efforts. So there's many different ways you can participate in research efforts. So one is participating in clinical trials. And that's where looking at the clinicaltrials.gov website or talking to your oncologist or neuro-oncologist to find out what are the trial options out there. So that's one way. And we often won't know if that trial is going to work for you or not. So it is very brave and courageous to actually participate in clinical trials. And that trial may not necessarily help you, but it may help provide information for other patients as well. So clinical trials is a big way to participate in research. There's periodically surveys, such as the American Brain Tumor Association survey that was conducted a couple of years ago, where patients and caregivers are surveyed on their experiences surrounding the diagnosis and the treatment. And that those surveys do provide a lot of information to us as researchers and to the community about where the needs are. What are the needs? For example, that survey that ABTA did conduct, the one that I mentioned during my talk, helped us really understand that, yes, all physicians, caregivers, and patients all uniformly agree that we need better treatments for patients and we need to do more research for patients with brain metastases. And then the other way you can participate in research is contributing to research efforts, contributing your tissue to research efforts. So most academic institutions now have what are called biobanks, which actually store tissue and blood for research purposes. And there you consent to have your tissue and your blood used for research purposes. So if your oncologist or your team has not talked about these biobanks, do reach out to your oncologist to talk about biobanks. You can always reach out at my website if you do have tissue that you'd be interested in participating in some of our tissue research efforts, such as the sequencing research efforts. Then there is information on our website too. So do reach out too. But yes, we do appreciate, and the field in general appreciates any participation in research, since that's how we actually move the needle for patients with these tumors.
Thank you so much for sharing that insight. Definitely an important piece in advancing treatments and quality of care as well. Another question we have here goes back to the basis of your talk, precision medicine and molecular profiling. Is this something that is readily available at all institutions? Does a patient, is it automatically done when a patient is diagnosed, or do they need to ask for molecular profiling to be done on their case?
That's a wonderful question. So the decision for the molecular profiling does depend on your tumor type and does depend on the clinical situation. The most academic centers have access to molecular profiling to do genetic testing. And it's standard for tumor types such as lung cancer, such as breast cancer, such as melanoma. And that's standardly done. However, some of the more extensive genetic profiling may not necessarily be standardly done. And that's where you talk to your oncologist to see what is available at your center. And there's commercially available tests too. So there's a company called Foundation Medicine that does extensive molecular profiling. So you can have your tumors sent over to Foundation Medicine, and it does extensive molecular profiling regardless of where you're at. And similarly, Guardant is another company. These are just examples of companies. There's many more out there, but I'm just giving you some examples of companies that do molecular profiling. Guardant, for example, does molecular profiling of blood. And so you can see if there's genetic changes in the blood that might help direct treatment. So definitely this is a question for your oncologist to see if they've done additional molecular profiling, and if it makes sense in your clinical situation. But there are commercially available tests that you could do as well.
Thank you so much. Dr. Kumticker in her talk actually talked about recurrence. When a brain mets patient does undergo a reoccurrence, do they then have additional molecular profiling done? Can the profiling of their brain tumor change?
So that's a fantastic question also. So when the tumor recurs, there's many things we think about in terms of what we do in the next steps. And I know Dr. Kamthekar sort of talked about that too. If surgery is on the table, and the patient does have surgery done, again, as part of clinical care, if that's the right thing to do for that, for that clinical situation, then additional molecular testing can be done of the recurrent brain metastasis. As well as as I talked about, you can do blood samples and have that done for, they're called liquid biopsies. So you can test the blood samples also for molecular alterations as well. And if that's not available at your institution, that the blood can be sent to Guardant, the company that I talked to you about, as well as there's other companies that look at blood as well. So it all depends on the clinical situation. But if there is tissue that was resected as part of clinical care, either from the brain or even outside of the brain, then often molecular testing is done, because then that helps us identify new potential targets for patients.
Thank you so much for that insight. Another question we have here is going back to genetic testing. You talked about how many institutions may have this available. Do you know if genetic testing is something that is covered by insurance, or do you know where a patient may be able to find that information?
Yeah, great question. So most insurance companies will cover genetic testing for specific clinical scenarios. So it's really important to discuss with your oncologist, who can help you navigate, and the oncology team who can help you navigate figuring out. Often we'll have patients actually call their insurance company to just verify that the testing is covered. So that is an important question, because sometimes the bills for the genetic testing can be quite high. So I think making sure that your insurance will cover it is really important, and that you can talk to your local team, your oncology team, the finance team at your institution, who can help you navigate that and provide you the resources to help you navigate that.
Thank you so much for sharing that advice. You had talked about the possibility of having tissue or additional blood samples sent out for analysis. Does this involve the patient having to undergo additional labs or additional procedures to get tissue, or is it the tissue and samples that were originally received maybe when they're diagnosed or originally had surgery?
So different scenarios are possible. So all of the above are possible. So the genetic testing can be done from the original tumor samples. If you have another tumor sample that was taken out at recurrence, then additional genetic testing can be done on that, because we do see changes. And that was some of the research that I talked about, is that we often do see changes. The brain metastasis may not necessarily look like the original primary tumor. And in terms of blood samples can be done in real time too. So often, we new blood samples will, new blood draws. So if you're going to get your blood drawn for other reasons, checking your lab for other reasons, then an additional sample can be sent out for additional molecular profiling.
Thank you. I think we have time for just one last question. This question is asking for brain tumor tissue. How long is that typically kept for? Or is there a standard across all institutions for how long a brain tumor tissue sample is stored?
Good question. It depends on the institution. Some institutions will keep the tumor tissue samples for more than 20, 30 years. Other institutions will keep them for 10 or 15 years. So it really is institution dependent. But they are kept for many years. In general, in most institutions, a piece of your tissue is kept for many years. So, and it's worth asking your oncologist too, if that tissue is available, if you wanted to do more molecular testing on that tissue.
Thank you so much for all of your answers and for all of your questions. I'm going to go ahead and turn it back to Emily to move forward with the rest of the program.
Thank you. Thanks, everyone.
Thanks so much, Dr. Brastianos, and thank you to our audience members for those great questions.